Good morning, friends. Myself, Dr. Sivapragasam, Assistant Professor, Department of Community Medicine, Sri Lakshmana Institute of Medical Sciences, Puducherry, affiliated under Bharat Institute of Higher Education and Research, Chennai. Today's topic is about Japanese encephalitis. Why Japanese encephalitis is a problem? Japanese encephalitis is the leading cause of viral encephalitis in Asia, now that poliomyelitis has nearly been eradicated. More than 3 billion people live in areas where Japanese encephalitis is transmitted, that means Southeast Asia. 50,000 cases of JE are reported to WHO each year. 10,000 to 15,000 deaths are reported each year. So where does JE occur? JE occurs in the Southeast Asia, as you see in the pictures. So history of discovery. In 1871, summer encephalitis epidemic was happened in Japan. It was the first outbreak. Then agent from human brain tissue isolated in rabbits, isolated of this virus produced experimental encephalitis in monkeys. First isolated from Culex. Culex mosquito is the main important vector. First mouse brain derived vaccines has been developed. 1952 reformed mouse brain vaccine has been developed. Key players in Japanese encephalitis transmission. As you know, in community medicine, we deal about agent, host, and environment. Coming on to the environment, can you guess any environment? What's the most predominant environment in Southeast Asia? It's none other than paddy fields or any agricultural fields. Coming on to agent, what is the agent? As I said you before, it's Culex mosquito. Next, what are the host? Amplifying hosts are nothing but the pig. So then coming on to the carrier hosts are nothing but the crane is an example. It's the cattle. And we are the accidental victims. So this is the epidemiological cycle. As you see, in irrigated rice fields, where there is animals and birds, the virus has been prevalent here. The mosquito, which is a vector, gets the virus from these animals, and finally it transmits to the uninfected humans, and then which is caused to the infected human, then disease has been occurred. After the disease comes, there is only 3 stages: recovery, death, full recovery. JE virus isolated from 16 other species also in India. Extrinsic incubation period is nothing but 9 to 12 days. Intrinsic period is nothing but 5 to 15 days. Incubation period is nothing but the entry of the pathogen to the first symptom. Cases are underreported. Cases are usually underreported because of bad surveillance. If the cases are reported, then the good surveillance system is being activated. Actual number of cases is probably more than 1,75,000. Death and disability from JE. Up to 30% of all patients with JE die. For those that survive, 30 to 70% are left with disability. Disability is both physical and cognitive because it affects the brain. Clinical spectrum of JE. Clinical spectrum is nothing but majority of the cases, as you see the pyramid, majority of the cases will be asymptomatic. Then comes the mild, moderate, and very few cases get severe, and very few of them, tip of that iceberg, will die. For every case hospitalized, there are likely to be 300 other people infected with JE. That means that it's a iceberg phenomenon disease, but with mild case or no symptoms. Age groups affected by JE. Children 1 to 15 years of age are mainly affected in endemic areas, but people of any age can be affected. Don't think that it's just a pediatric age group disease. It can affect any humans, but pediatric extremities of age will get the aggressive form of the disease. Age distribution, as you can see, 1 year to 16 years are getting affected here. And here you can see above 15 years are getting affected. This is in the Nepal, this is in the India. 2 pattern of transmission of JE. JE may be spread seasonal. Seasonal is during the paddy season, during the rainfall season, or year round, can be endemic in Bali, Indonesia. Seasonal variation in JE incidence. Sometimes during rainy season, sometimes in the year, if you see like 99, 2000, like consecutive years, there was an acute outbreak in the 2004. You see, no, there is a very acute number. In shorter duration time, there is increased number of cases. This is called an epidemic. here also in Assam. This is in Uttar Pradesh, this is in Assam, and also in Andhra Pradesh. Remember, if it is in the flat line, that means that it's endemic. But if it's an acute cases of case, it's of importance. It should be noted. It should be notified because every single case means 300 subclinical cases are there. So, Japanese encephalitis in India, evidence of JE viral activity was first discovered in NIU. NIV is National Institute of Virology, and clinical case in Vellore, Tamil Nadu, then JE outbreak. This was in West Bengal. What is encephalitis? Encephalitis is an inflammation of the brain tissue due to the infection, most often caused by virus. Remember, you can classify into virus, bacterial, fungal, like that, into the bloodstream and then into cerebrospinal fluid, leading to destruction of neural cells and inflammation of the brain camera. It can be primary or acute encephalitis. May also result from viral mediated inflammatory response in the brain following an acute systemic infection, or even it can be secondary post-infectious encephalitis. Viral infection of the central nervous system resulting in following clinical symptoms. Remember, throughout your life, please remember, in meningitis there will be neck stiffness. Meningitis means it can have neck stiffness. Encephalitis, same fever, headache without neck stiffness. Once it goes to neck stiffness, it means that it is meningitis. How to distinguish encephalitis from meningitis? As I said, a patient with neck stiffness and photophobia, so classic signs of meningitis, could in fact also have an encephalitis called meningoencephalitis. So if it's a mixed picture, it can be the patient might also come with encephalitis as well as neck stiffness and headache. It is important to recognize other infectious and non-infectious causes, particularly those which are treated. That's why history taking is very important. As you see, this is the difference which I want to tell you. This is an encephalitis and this is a meningitis. The main important point comes here. Please remember, neck stiffness. It's and photophobia. It's not present in encephalitis, but it is present in meningitis. But if it's a meningoencephalitis, both will be present. Otherwise, cranial nerve palsy will be present in the encephalitis occasionally. Here it won't be present. In neurological wise, it will be affected in encephalitis. Brain matter wise, it will be affected in meningitis. And seizure will be present here, it will be minimal. I don't think that it won't be present. It can be shown. Any seizure is an emergency. What causes encephalitis? As you know, there are viral, bacterial, and other causes. Most common is the virus. What are the viruses? Arbovirus, enterovirus, mumps, varicella, herpes simplex virus, and influenza and rabies virus. Large number of reported cases of encephalitis are due to an unspecified cause, which all the investigation will be done in the window period or some other time, which is not matching with the positive result. Clinical approach to Japanese encephalitis. As you know, Japanese encephalitis is classically present as an acute encephalitis syndrome. Fever, impaired mental illness, seizure, and classic paralysis. From a clinical perspective, encephalitis due to JE is indistinguishable from encephalitis caused by other agents. So you can't straight away go and tell this is Japanese encephalitis, but we have to rule out all the other causes also. Epidemiology, that's why epidemiology is an important factor. Therefore, this presentation will focus on recognizing acute encephalitis in general. Non-viral causes of encephalitis. Coming on to non-viral causes of encephalitis, what are the non-viral causes? As I said, bacterial, tuberculosis, which is the most important in India, cat scratch disease, brucellosis, typhoid fever, spirochetes, leptospirosis, syphilis, Lyme disease, fungi like cryptococcus, histoplasmosis, other infection like cerebral malaria, toxoplasmosis, and amoebiasis. Who's at risk for encephalitis? As I said, anyone can get encephalitis. However, the following age group are at risk. What are the risk patients? Extremities of ages. The younger the patient, the elderly patient. More than 60 and less than 15 years of age. Persons with HIV. As you know, HIV can be immunocompromised state, positive state. Then persons having immunosuppressive drugs. Person living in encephalitis endemic areas. Endemic areas are constantly present. Endlessly the cases are present, but there won't be any peak. Cases are constantly present throughout the year. So clinical approach to encephalitis, how can you do? Clinical manifestation, considering differential diagnosis, taking a proper history, considering differential diagnosis, taking a good history is very, very important. Performing a physical examination, check for neck stiffness, check for fever, check for all the signs, check for photophobia. Identifying treatable versus untreatable process, which can be treatable, which is not treatable. Reported suspected cases for disease surveillance also. Clinical, clinical manifestation of encephalitis. Coming out of the clinical manifestation, this is nothing but, as you know, any itis inflammation will have rise in temperature, fever, headache, vomiting, occasionally accompanied by seizure. Seizure means brain is involved. Mental status changes, brain is involved, and focal neurological effect, like focal, particular part of the brain is. Any patient presenting with fever and an abnormal neurological exam should be evaluated closely for encephalitis. Please do rule out brain causes whenever you are having some problem. Important signs of encephalitis to watch in children: vomiting, body stiffness, constant crying that may become worse when the child is victim, full or bulging fontanelle. Common symptoms of encephalitis. What are the common symptoms of encephalitis? As you see the baby, headache, vomiting, diarrhea, lethargy, irritable or restlessness, change in consciousness. These are the common symptoms. Differential diagnosis of encephalitis. What are the differential diagnoses? As we know, meningitis is a very important differential diagnosis, which can be due to TB or brain abscess, cerebral malaria, rickettsial, spirochetal, or toxoplasmosis, intracranial hemorrhage or tumor, trauma, toxic ingestion, hypoglycemia. Remember, always check for sugar levels. Whenever a patient comes with any head injury or any loss of consciousness or any seizure or anything, first we'll check 3Gs. Remember 3Gs. One of the main G is glucose. Guillain-Barré syndrome. Guillain-Barré syndrome is again a neurological deficit. What are the other two Gs? Nothing but ECG and ELG. Steps in conducting patient history. What are the steps? Remember, chief complaint, history of presenting illness, review of systems. Review is you will have a doubt and again go back and ask the history again. Past medical history, family history, and social history. Important questions to ask a patient representing patients of encephalitis. Any symptom of viral prodrome. Remember, prodrome is nothing but the fever stage. Upper respiratory tract infection, cough, malaise, decreased oral intake, diarrhea, nausea, vomiting. Any recent exposure, ill contact, travel history, occupation, pets, tick or mosquito bites. Remember, these are things very important for the epidemiological purpose. Perform a thorough neurological review of system. Headache, photophobia, neck stiffness, poor sleep, change in mental status, irritability, and convulsions. Example of an history. What are the chief complaints? What brings to your medical attention? When did you become sick? What were the first symptoms that how you enrolled? What's the headache? What's the seizure? What's the fever? What is the first symptom? Symptom is what the patient tells to us, whereas the sign is what you elicit, like neck stiffness. If you elicit the neck stiffness, that's called the sign. Example of history. Review of system, go back and check for fever, vomiting episodes, food and fluid intake, urine output is very, very important. Rash, any fever with rashes, you have to rule out all the differential diagnoses. A neurological, headache, seizure, how many, how long, when was the last seizure, shaking of entire body or part of the body, unable to arouse, irritability, post-ictal status, ictus, abnormal facial or eye movement, any facial palsy is there or not, tremors or abnormal body movements, unable to walk or talk. Example of history. Pre-existing health problems, history of abnormal chest x-ray, current medications, allergies, and immunization and other status. In particular, JE, measles, mumps, and Haemophilus influenza B. Any household members, family history or social history, any household members, recent illness, any family history, recent illness, any recent animal bites and exposure to toxins, any travel with the previous 2 weeks. Physical examination of a patient with suspected encephalitis. Remember, always patient comes with seizure or LOC or anything. Remember this ABC: airway, breathing, and circulation. Always patient, any critical patients comes to you with loss of consciousness or seizure or without responding. Check for ABC and measure all the vitals. Clear of the airway, clear of the breathing and circulation. Rule out Cushing's triad. Cushing's triad is nothing but hypertension, bradycardia plus irregular respiration. This is a medical emergency. Indicates increased intracranial pressure and impeding cerebral herniation, which can cause irreversible damage. And it's very highly progressive disease. Every moment, every second is very important. Perform thorough neurological exam. Emergency signs and reasons for referral. When do you refer? If you are a medical doctor in a PHC setting, you can't do all the intubation techniques. You can't do tracheostomy. You can't do ventilation. Some of the things are very difficult. Best, like for example, the patient is in shock. You have to rapidly revive and refer the patient. Continuous seizure, you can't do anything. And a severe deterioration with lethargy, sunken eyes, which needs ICU management. Any patient which needs ICU management, COVA, convulsion, distress, please do the primary management, primary ABC management, and refer the patient as early as possible so that the time delay is reduced. Then coming on to the overview of the physical exam, check out the vitals, temperature. What are the vital signs? Temperature, heart rate, respiratory rate, blood pressure, and weight. General appearance. See whether the patient is drowsy, severe wasting, edema is present or not, skin, whether there is capillary refilling is there or not, rash, petechiae, blood vessels losing. That means that platelet is reduced, which can also, you can rule out dengue causes. Dengue causes can also be ruled out if there is petechiae or hemorrhage. Diffuse adenopathies. Head, eyes, ears, nose, and throat. Pupils equal and reactive, corneal clouding, neck stiffness is there or not. Heart, gallop rhythm, slow heart rate is present or not. Chest, rails, soul temp, repetitions and newer temp. Crackles, signs of pneumonia, respiratory distress or not. Enlargement of liver spleen is there present or not. The complete thorough systemic examination. The neurological examination. The neurological exam is an encephalitis patient is part of the general physical examination. Thus, the neurological exam should always be preceded by and interpreted in the context of more general examination. Remember, the neurological examination is very important. You have to rule out whether brain is involved or not. The neurological exam involves mental status, level of alertness. Alert response to voice reacts to pain unconscious. You can use Glasgow Coma scale, which is a very important scale, or a AVPU scale. Orientation, memory, speech, etc., irritability, and aphasia. Cranial nerves, neurological exam, coming on to other neurological exam, cranial nerves, pupillary reactivity, eye movements, fundoscopic exam for papillary edema, facial muscles, weakness can due to facial nerve. Motor exam, assess strength, tone of upper and lower extremities, compare sides, abnormal movements or posture. Sensory system, assess pain, vibration, temperature, sensation, and compare the sides, left side and right side. Compare. Keep one as control as normal and the other one affected part as unaffected part. Neurological exam, deep tendon reflexes, check for all the tendon reflexes, coordination and gait, finger to nose test, coordination, whether the cerebellum is involved or not, tandem walking test, all these tests you can do. At completion of physical examination, based on the symptoms and signs, provide an initial assessment. Determine which laboratory test, minimalistic laboratory tests which are required. By the history taking and itself, you have to get the differential diagnosis. With those differential diagnosis, by examination, you have to confirm your TD and come on to one or two provisional diagnosis. With those provisional diagnoses, you do the test to reconfirm. Develop a care plan, communicate the information with the patients and caregivers, report suspected case of encephalitis to local health authorities. Remember this point. Any encephalitis which is a notified disease. Acute encephalitis syndrome is a very important essay question. For surveillance purpose, WHO defines a case of acute encephalitis by acute febrile illness and a change in mental status such as confusion, disorientation, inability to talk, coma, and or plus or minus new onset seizure, explaining excluding simple febrile seizure. Remember, excluding simple febrile seizure. Fever seizure should be excluded. Uh, uh, Increased temperature can also cause seizure in children, which is reversed when you give paracetamol. But here there is a change in mental status, confusion, disorientation, inability to talk or turn. Simple febrile seizure is nothing but a single seizure lasting less than 15 minutes with recovery of consciousness within 16 minutes. In child age, 6 months to 5 years. Surveillance for cases of encephalitis. For surveillance purposes, JE is most commonly reported under the heading of acute encephalitis. WHO's guidelines for JE surveillance, syndromic surveillance for JE is recommended. This means all cases of acute encephalitis syndrome should be reported. Laboratory confirmation of suspected case is done where feasible. Laboratory test of suspected encephalitis. Remember, any meningitis or encephalitis which involves CSF or brain, we have to do lumbar puncture, CSF analysis and culture, blood routine and secretion culture, serum and CSF antibody testing, neurological testing, CT or MRI, or even EEG. Laboratory test on CF, you have to do cell count, glucose, protein, ram stain, India ink preparation, stain for acid bacillus, this for TB, viral bacterial fungal cultures, and anti-JEV, IgM, ELISA. This is a test for Japanese encephalitis and JE RT-PCR if available. This is a more molecular test. Remember, this is a very important picture from here, from microbiology, medicine, pediatrics, from any subject, this question can be asked. How will you differentiate CSF finding? Always remember, normal CSF, you should not have any polymorphs or very minimal. Lymphocytes should not be there. Glucose should be 40 to 80. Glucose should be present. Okay. And CSF plasma should be, glucose ratio should be 66%. Protein should be 5 to 40 milligrams per deciliter. Culture and gram stain should be negative. Coming on to bacterial and TB. Remember, bacterial and TB both will be equally present. In bacterial, as you see, glucose is decreased. Here also decreased. Only thing is here cells are very much increased. Here 25 to 50, and protein will be increased. Protein will be increased. All protein will be increased, and lymphocytes will be late. Lately it will increase. Here it will be increased. And coming on to viral meningitis, glucose will be normal. Glucose and CSF plasma ratio will be very important clinical feature. CSF finding feature. Laboratory tests on blood includes blood count, differential, glucose, electrolytes, cultures, unspecific, malaria smear, and all the other dengue serology, communicable disease tests. Additional tests to be considered: blood, liver enzymes, blood urea nitrogen, creatinine, ammonia, calcium, magnesium, blood gas, urine analysis, culture, brain biopsy. Prognosis depends on the cause and severity of illness, patient's age. Mild cases recover in 2 to 4 weeks with supportive care. Severe encephalitis can lead to numerous complications like hearing or speech loss, blindness, permanent brain and nerve damage, behavioral changes, cognitive disabilities, lack of muscle control, seizure, or memory loss. Important points to remember. Acute encephalitis is a medical emergency. Any patient presenting with fever and impaired mental state or neurological exam should be evaluated for encephalitis. Diagnosis of encephalitis is clinical. Don't forget to value of a good history and physical examination. All suspected cases of encephalitis should be reported to local authorities. These are various references. So coming on to an important point, what is the control? How will you control Japanese encephalitis? First, you have to understand the transmission. Remember, the virus is being transmitted through the cattle cycle, amplifying cycle, cattle cycle from vector called Culex. And humans are incidental, accidental host. Remember, control option should be mosquito control, tick control, and human intervention. All three should be targeted. Coming on to mosquito control. Spraying mosquito habits with insecticide, time consuming, expensive. It is difficult to cover all the mosquito habitats and causes environmental pollution also. Bed nets. Mosquitoes bite at dusk before people are infected. It can be told as not the best solution, but in integrated vector control approach or program should be implemented aggressively in those endemic areas. Pig control, segregating, slaughtering, or vaccinating pigs economically not feasible and difficult. Other animals like birds may also act as an amplifying force. So, if pigs are eliminated, JE will not disappear because other cattle are also being affected. Conclusion: human vaccination is the only effective long-term control measure, remember, against JE. All at-risk residents should receive a safe and efficacious vaccine as part of their national immunization program. JE vaccination. What is JE vaccination? According to WHO statement, where affordable, JE vaccination should be extended to all endemic areas where JE is considered as a public health problem. Scientific evidence for JE immunization. There is compelling evidence that human immunization is effective for controlling JE. Studies in Korea and Japan showed this after immunization, all the epidemics has been reduced drastically. Evolution of JE control in Thailand. As you see, after vector control and vaccination, it's a comprehensive approach. Everything should be involved. Vaccination as well as prevention of mosquitoes, prevention of all other prevention strategies. It's like vertical program like outbreak spraying, health education, integrated program like outbreak control spraying, health education, and then vaccination. Status of JE control with immunization. This is the axis. These are the status of the JE transmission. The orange part are the transmitted state. This is a comprehensive immunization program is being affected. Candidate for expansion or development. Clinical trial states. JE vaccines. What are the vaccines? JE vaccines currently available fall into two categories: inactivated vaccines, live attenuated vaccines. Inactivated vaccines first licensed in Japan in 1954. The most widely used and available vaccine has been produced by several countries, including Japan, South Korea, Thailand, and Vietnam. Mouse brain derived. Then comes live attenuated vaccine, JE vaccine, SA 1442 vaccine. First licensed in China in 1988, used extensively in China. Recently licensed and used in Nepal and South Korea also. Live versus attenuated JE vaccine. Live attenuated vaccine has the following advantages. Remember, live vaccines have certain following advantages: simpler schedule, better safety profile, longer duration of action, cheaper price. These are the live vaccine advantage over the inactivated mouse brain derived vaccine. Japanese encephalitis. JE vaccine issues. No JE vaccine has been pre-qualified by WHO. There are supply problems with the inactive vaccine. It is difficult to produce and supply is insufficient for global needs. Mouse brain derived vaccine, JE vaccine. Current schedule is 3 doses between 1 to 10 years of age, 0, 7, 28 days, 1 booster dose, and 3 years. After introduction, 1 to 2 years, vaccination should be completed in the community at least 1 month before anticipated rise. JE vaccine conclusion. Vaccine supply problems, cost, scheduling difficulties, and other issues have resulted in slow progress of implementation of JE immunization in some other countries. However, many countries are making good progress towards control of JE by immunization. Remember, from this class, Japanese encephalitis, which is an important vector-borne disease, has been discussed thoroughly with the neurological examination, general physical examination. If you are posted as a medical doctor in a community or the field, please do identify that whether the surrounding paddy fields or the vectors are controlled or not. All strategies are important. Vaccine strategy is important. Vector control strategy is important. Cattle rearing should be properly maintained. All prevention strategies should be involved because not a single approach, as we say, not as in epidemiology, not a single approach will end all the outbreaks. Our approach is to prevent the vector-borne diseases and to eliminate or eradicate the disease per se. Vaccination, which is the last stage, it's a very highly difficult stage. So you have to make everyone to come to the center, give the vaccine, and make them to follow the protocols. And disease should be treated properly. Remember, Japanese encephalitis is the iceberg disease. Even one case, it should be reported, it should be notified, because these diseases, no, it might lead to uh, iceberg disease phenomenon. One clinical disease, one confirmed disease, means that 300, 400 cases are there in the community at the subclinical stage. I hope you don't have any doubt in today's class. Japanese encephalitis, which is a very important essay question. The agent is the Culex, and the host is the nothing but the cattle or the pigs, and humans are the intermediaries. And finally, the environment, paddy fields. And approach should be vector control, vaccination. All these are the important strategies in Japanese encephalitis. I hope you have a good knowledge about Japanese encephalitis. In the future, if this question is asked, it can be asked in any format, like acute encephalitis syndrome, right? And I say about acute encephalitis syndrome, which is a broad question, which is discussed as earlier. And Japanese encephalitis per se also. Even JE vaccine. JE vaccine can be asked as a short note. And all any type of question which is as and QLEX, remember QLEX, how you differentiate QLEX with EDs with Anopheles. Remember, EDs is a you will have a white dots will be there. QLEX, no white dots. And the sitting position 45-degree for Anopheles, whereas here hunchback will be there. These are the important features. These are the basic things which you need to understand as a public health expert. Hope we will meet in a different session with a different topic. Thank you once again. I thank Lakshmanarayana Institute of Medical Sciences, Puducherry, and Bharat Institute of Higher Education and Research, Chennai, for helping me to organize this online e-content lecture. Thank you.